So when doing a focused GU assessment for this particular complaint, which is dysuria and pain with intercourse, I would begin first actually by assessing the abdomen. First with the patient sitting up, I can do an assessment of CVA tenderness, doing some percussing of the area using my fists in the back around the 10th, 11th rib CVA margin. I would then have the patient lie down and do an abdominal assessment. First doing a visual inspection, looking at the skin, looking for any masses, looking for any ascites, looking for at venous pattern, looking for any varicosity changes, and then I would proceed to doing auscultation, listening at the abdominal arteries, and then listening to the bowel tones, looking for normal active bowel tones with any sign of distant or delayed bowel tones or hyperactive bowel tones. Then proceed to percussing the abdomen, listening for any dullness or hyperresonant sounds, and then do palpation, looking for any guarding or tenderness, especially in the lower quadrants. I may do an assessment of the liver and the spleen, but perhaps the spleen in this case, assessing for any hepatosplenomegalia. From that, I would have the patient prepare for the pelvic exam, assemble my equipment, talk the patient through the exam, have the patient proceed into the lithotomy position, have her rest her feet in the stirrups, and inform her she's to scoot down on the bed. Informing her she may feel like she's sliding down, but I won't let her fall. I would walk her, talk her through, have her consent to testing, culture testing, specifically probably gonorrhea and chlamydia in this case, and due to her age, sexual activity, and complaint. I would not perform a pap smear in this instance due to the likelihood that it would be abnormal in the current situation. I would then talk the patient through each part of the exam and what we'll be doing. And then after the patient is in the position, I would don gloves and let her feel my touch on the inner thigh before proceeding to inspect the external genitalia, looking at feeling the inguinal hernia or the inguinal lymph nodes for any swelling or any lymph involvement, and then proceeding down, looking at hair distribution, looking for any lice or nits, looking at the amon pubis, the labia majora, the labia minora. I would then assess the Bartholian glands, expressing for any discharge or tenderness, swelling, and then the Skene's glands, milking for any discharge. I would open the vaginal opening and have the patient bear down, looking for any rectocele or cytocele. I would have the patient squeeze around my fingers, looking at tone, and then assess the perineal area, looking for any excoriation, any lesions, or hemorrhoids. I would then inform the patient we're going to proceed with the speculum exam, which I will have in a warm bath of water. So we won't use lubricant. We wouldn't want to damage any cultures we're going to obtain. So I would let the patient know I'm going to be placing a finger in the vaginal opening to help create more space for the speculum, entering with the speculum in the introitus at a 45-degree angle and tilted. I would, once I'm in the introitus, I would then turn the speculum horizontally and exert downward pressure so as not to bump the urethra or clitoris, and with downward pressure, continue into the vagina until I reach the cervix. Once I'm at the cervix, I can lock the blade open. If I can't visualize the cervix, I can relax the speculum and move back about a centimeter and angle downward more or to the side before opening again. Once I have the os and cervix in sight, I can lock the speculum open before proceeding with my cultures, noting any discharge, any lesions or masses on the cervix, any changes in the os or Cundler's squamosal-columnar junction. Take my cultures, and then once I'm finished, I can remove the speculum from the cervix. I would unlock the speculum, remove it from the cervix before closing, and then close, observe the vaginal walls at this time for any dryness, any lack of rugation, any discharge or lesions. I would then again tilt down at a 45-degree angle and to avoid bumping the clitoris or urethra and remove the speculum. At this point, I would let the patient know we're going to do the bimanual exam. So I would change gloves, lubricate my fingers, and let the patient know I'm going to be inserting 2 fingers into the vagina. I'll feel the vaginal walls for, again, any lesions or masses, any pain, tenderness, and then proceed up to the cervix, moving my fingers back and forth for any cervical motion, tenderness. Watch the patient's face, ask if there's any tenderness there when I do that. I'll then, with my ungloved hand, feel in the midline pubis area with sweeping motion, feeling for the uterus depending on its location. May feel in the external hand or the vaginal hand, and noting size, any irregularities. I would then move my fingers internally to feel for the right adnexi in another kind of more gentle sweeping motion, and then noting the size or any masses or lesions, any increased tenderness. It may be uncomfortable, but it shouldn't be painful for the patient. And then proceeding to the other side to feel for the left adnexi. When that's completed, I will remove my fingers and let the patient know that that portion of the exam, that the pelvic exam is over, and they can sit back up, and after removing my gloves, I'll give them tissues to clean up and ask if they have any questions, and that would complete my exam.